severity classification grades using both the revised Atlanta classification and the determinant-based classification. And at the end of the day, we're also going to record outcomes to include development of organ failure, pancreatic necrosis, the length of hospital stay for the patients, and if there was any mortality. So as you can understand, this is a pilot study. It's an observational study, but still, if we are able to have a lot of centers involved throughout the world and motivated investigators that they will be committed in enrolling large numbers of patients, at the end of the day, just from this cohort, there will be a lot of very important findings to be reported in the forms of manuscript. But again, this will be a pilot study. Right now we have a huge interest from centers throughout the world, but these centers, including University of Pittsburgh, have to prove that they're going to be committed, that they're going to be, place the time and the effort to enroll patients and record prospectively the data. And at the end of the day, when the study is, has advanced, then it will be, that will serve as the platform for future collaborations. And at this point, I think we will be able to start talking about randomized controlled trials, and we're going to be able to start talking using our pilot data for funding opportunities through organizations such as NIH or through GI specific organizations. We're going to move now into some practical points of the study, because it's very important for all of you to have an idea how can you start, what is needed to be done at the first very critical steps. The first thing that you will need is approval by ethics committee of your institution. In the US, we call that the IRB, the Institutional Review Board. And maybe if, at this point, I don't know if we can do that, Venkat, if we can see how many of the attendees are already enrolling patients, and they do have approval for such form of studies. So if any of you could click on the hand, correct? Yes. That would give us an idea if there are already centers that could start enrolling even starting tomorrow. So I'll give you a couple of seconds to maybe in your computer or your smartphone locate the hand icon, and if you indeed have that already set and run, we can you can let us know. Nothing.
Dr. Gellert.
So Dr. Gellert, so one of our collaborators, Dr. Gellert from Chicago, is ready to go, and that's very important.
And Mario, please. Please do.
And two, can you read the names? I cannot see them.
Konstantinos.
So Dr. Triandafilou also, and Dr. Pelaez from Dr. Triandafilou from Greece, from Athens, and Dr. Pelaez from Mexico are good to go as Dr. Yiannopoulos. I hope I pronounced it correctly, Yiannopoulos. Yes, so or Yiannopoulos. Yeah. Yiannopoulos, I think another physician from Greece. So that's very encouraging. So there are already at least five or six centers that could potentially start the enrollment. So for the rest of you, that would be the first step. Contact your ethics committee, let them know about the study, and do all the appropriate steps to submit your protocol and get approval so you can start. The nice thing is that doing an observational study, this is a minimal risk study. There are no interventions included, so probably this process will be fairly straightforward and fast. At the same time, we're going to be recording our data through a website, and so all the centers will use the same questionnaires and the same enrollment steps, And this website, which is called REDCAP, and we're going to talk about that in a few minutes, is going to be run by the University of Pittsburgh. So at some point, you will have to ask your ethics committee if there's a need for data transfer agreement, if this is applicable in your institution, and if so, you will have to fill that in. At the same time, I would like to let you know that here at the University of Pittsburgh, we have an ongoing active running protocol, and we'll be more than happy to share it with you. So what exactly was the protocol that we submitted to our IRB, as well as the questionnaires that we fill in, and that will be a very helpful tool for you to start. So again, this is the first critical step, approval by the ethics committee of your institution, and then moving ahead, there has to be a nice plan of identifying these eligible patients. There are patients that come into your hospital with acute pancreatitis. How can you identify them? What we do at the University of Pittsburgh is collaborating with the clinical laboratory of our hospital and having them sending us twice a day via email a lipase report, meaning whichever patients in the hospital have an elevated lipase, we are alerted about them, and then we have permission by our IRB to go into the medical records of these patients, screen them, and see if they are eligible for the study. Another way that we are approaching and identifying patients in our institution is through the pancreatic biliary service. So we have a committed service that takes care of our patients with pancreas and biliary problems, where both myself and Dr. Yadev rotate through, and we have an open line through our research coordinator, letting them know about potential patients as well. These two steps have worked great for us, but there are other approaches, and another approach that might be very useful in other centers is actually getting information or potential patients through the emergency room of your institution. And actually that will be excellent, because this way you will be able to approach these patients and enroll them in the study early in their course of their hospitalization, so all the recording of the data will be on a prospective fashion. So these are the options that you have to consider. So you might need to go and talk with your ER colleagues or approach the clinical lab managers and see if you can generate a report like that. Our goal is, if possible, to include all patients. So we're looking for consecutive patients. If we're able to do consecutive patients, that will give a different, a higher strength and weight into our study. Again, as I briefly mentioned, it's important for the data collection to be timely and in a way prospective. So when we are trying to record the first 24 hours IV fluids, this ideally needs to be done at the end of the first 24 hours. If we let go 1, 2, or 3 weeks and then retrospectively go back into the data to record the fluids, in a way we're missing the prospective design and fashion of the study. So this is something important. The person that will be assigned to do the work needs to, if possible, access and record those data on a timely fashion. We already mentioned that. And then the data, as I briefly mentioned, will be recorded into a web-based sheet method, which is called REDCAP. And at this point, I will pass the mic to Venkat Akshintala, one of our young, bright physicians at the University of Pittsburgh, who's going to talk to us briefly about just an introduction to REDCAP. Venkat?
Thank you, Dr. Papakristov. So briefly about REDCAP, for those who have not already been using it, REDCAP is a web-based application for managing online databases, and we are going to use this software for managing our acute pancreatitis registry. So it is a secure registry. It's HIPAA compliant. So you need not worry about the IRB approvals for using this, because we are going to store all the data in this. We try to avoid storing the patient identifiers. such as the name. So we will have to use a unique ID on this registry. But as I said, this will be stored in the secure server at the University of Pittsburgh, and it is HIPAA compliant. And access will be given to all of you through unique IDs. And we would be able to know like who is doing what and have a data trail. We will have data access groups. So there will be separate data access groups for each of the center. Each group has its own site PI, its own site coordinator, and we would be able to track what's going on at each center. Each center will be able to see only their data. They cannot see other centers' data. But we will have a study manager who will be able to see all data except for the patient identifiers. And we can train the coordinators in how to use this. And based on our previous experience, it takes only like half an hour or 1 hour to train people how to use this. It's a very simple, straightforward software. And this is how the program looks like on the computer screen. So it's pretty straightforward to fill in. But most IRBs mandate that all data should be recorded on paper and then filled onto the computer. So there is a separate paper format of this in PDF form. We can print it out, fill it, and later add it to the computer. And we can also review the progress at each center. We can see how this data filling has been going on, whether there is anything incomplete, and whether there is anything pending. And we can also use pretty easily import and export data from this. For example, if you already have an ongoing study at your center that uses Access, Excel, or something else for recording data, we can easily transport the data from your database to REDCap. And we can also extract data easily for the analysis purposes. So I hand it over again to Dr. Papacristo for moving on.
Great. So at this point, we would welcome Dr. Vikesh, a great friend from Johns Hopkins University, a very upcoming but also prominent at this point pancreatologist. An excellent between Hopkins and several centers in India. We'd like him to share with us his experience on organizing that and also give us important tips that we think would be helpful. Dick?
Good morning, everyone. Can you hear me?
Yes.
Okay. All right. Wonderful. Thanks for the introduction, and it's nice to see everybody on this bright, cold, early morning, especially here on the Eastern Seaboard. And of course, I welcome everybody who's joined us from a farther distance. So what I'm going to talk about is just really largely just some of my observations with using REDCap and trying to conduct a multi-center study that really is international in scope. I think REDCap is a fantastic program. It obviously affords a method of sort of streamlined data entry regardless of where you are. As long as you have access to the internet, you can enter data and it's going to be secure. So I think that's very important for anybody using REDCap. There's a couple of things that I think are important to consider, and I'm sure that some of you who are on this call have used this program and have also recognized some of these potential limitations and challenges. But I think one thing is that's going to be very important for all of us is that we're going to have to make sure that we create a very user-friendly platform and interface for data entry. Certainly REDCap can get very, very complicated, and I think that the more data we add, then or the more complicated the data becomes or the more difficult it becomes to enter, I think that might limit our sort of final usable / analyzable type data. So you really want to come up with what I think is going to be the most streamlined, concise data set that can be put into a very easy to use format. So I think to that effect, it's going to probably be important that whatever fields of data entry we all want to enter, we have some general agreement that it's going to be possible to enter that, and so that we can create the best data sheet really up front. Because I think going back and changing the data sheet becomes very, very difficult. So if we're several months into this and we're making changes, that's not actually going to be a lot of our centers we're going to have to keep that in paper form as well as enter it into REDCap. So I think having one person who can do this and do it reliably is going to be very important. To that end, while all the centers will have one person or maybe more than one person entering the data, I do think that we should have somebody at one of the sites who kind of oversees the data across all of the sites, because that's sometimes the easiest way to pick up where the problems and challenges are in terms of ensuring data completion, ensuring that the data is complete, because sometimes folks will enter maybe 10 fields and there's actually 20 to fill in and they'll leave the other 10 out. So unless you have somebody kind of overseeing all of the centers, I think it can be very difficult. So that's the other thing to think about. And I think the other thing that's going to be important is once we're up and running that we spend maybe have at least a monthly meeting or maybe a meeting every 2 months between all of the sites, just so that we can sort of share some of our experiences in terms of some of the challenges and that actually come with using a centralized data system, because I'm sure that issues will come up and we'll have to make sure that we can adjudicate them before we go too far down in our data collection process. So those are just some of my thoughts. I think I guess we're all open to some discussion now, right, George? I'll leave it there.
Actually, we're going to move on with completing the presentation, the second half, and then we're going to have time at the end for discussion. So all of you that are participating, please, whenever if you have questions at the end or if you want to comment on how things are moving along, you will have time at the end. Using a webinar, sometimes chaotic and many people talking at the same time. So we're going to do that at the end. But please, all your comments and questions will be, there will be time for them to be addressed. Rick, I think this was very, very informative and helpful, and sharing your experience with REDCap, that it's feasible and safe, that's also important for all of us to know. And actually, in a few minutes, we're going to talk in specific what is the time plan, what we should do from now on, and we're going to have very, very tight and set time points to move forward. So this will be addressed, as well as the issue with the research coordinator. Moving along, we're going to discuss a little bit about the questionnaires right now. I want you to understand that an initial draft of a questionnaire was developed during Pancreas Fest last year, and since then many of us, including leaders in the field such as Peter Banks and John Winstor, have been involved in adding or removing certain variables. And this is the form of the questionnaire where we are now. I want you to understand that this is already an advanced draft, but we plan to give you some time within the next few weeks if you really think that there are some crucial additions that need to be done. At this point, I will pass the mic to Stratos Kudroubakis, who's going to briefly go through all the different variables that we plan to include in our initial data collection sheet. Stratos?
Hello, everyone. I would like to thank Dr. Papachristou for his kind words. I'm going to introduce you to the questionnaire that all the investigators attended the meeting of the Pancreas Fest last summer suggested that are the variables that we would be interested in. We try to keep this short, but at the same time record all the variables that we would need. So the questionnaire will be mainly grouped into 5 classes. So the first class will be demographics and disease characteristics. The second will be the management of disease, then the outcomes, and follow-up of follow-up questions. Demographics that we would be interested in will be the age, sex, race, BMI, we decided that we would like to record comorbidities in the form of Charson comorbidity index, and also other demographics such as smoking, alcohol use, and pre-existing diabetes, meaning that history of diabetes, either type 1 or type 2, before the onset of this attack of acute pancreatitis. These are the demographics we would like to try and record. Moving along, we would be interested also in recording the use of medications prior to this attack of acute pancreatitis, and mainly the use of non-steroid anti-inflammatory drugs in the last 7 days, and also statin use. The acute pancreatitis characteristics that we would like to record include the etiology of the pancreatitis, the number of prior acute pancreatitis episodes if this is not the first attack, the date and time of the onset of symptoms of this attack. So it is very important to record the exact date that the pain of pancreatitis started, and this can be tricky depending on the etiology. And also important will be to record the date and time of the initial admission, and this, for the centers that are referral, this is we mean the time and the date that the patient entered the initial hospital, meaning before they transferred to the tertiary center, and also if they are transferred or not. Moving ahead, some early prognostic markers and scores we think are really important to record, including the BUN, hematocrit, CRP, and SEER scores. And this will be recorded on admission and at 24 hours. The management of acute pancreatitis, we would be interested mainly in the amount of IV fluids administered to the patient in the first 24 hours, and this can be challenging, but it's very important to record. The need of ICU care, probably the duration that the patient needed to stay in the ICU, the nutritional support in the form of either enteral tube or TPN. If any early intervention was required, and by early we mean within the 2 weeks of admission, or any delayed drainage debridement in case some necroma was developed and drainage was required. And also the type of this intervention will be recorded, and it includes mainly either open surgery or minimally invasive techniques, including percutaneous drainage catheter placement, endotherapy, or laparoscopic drainage debridement. The clinical outcomes we would be interested in will be the development of organ failure, and if this is a single organ failure or multiple system organ failure, if this is persistent or transient, the development of pancreatic necrosis and possibly the new entity peripancreatic necrosis alone, other symptomatic local complications, the duration that parenteral narcotics were utilized, and then the total length of hospitalization and the inpatient mortality. Also, after the first 48 hours, we would attempt, as Dr. Papachristou mentioned earlier, to classify patients based on the new severity classification systems, namely the revised Atlanta classification and the determinant-based classification. Other than that, all the investigators that participated in the Pancreas Fest meeting last summer, they suggested we have a follow-up questionnaire in the window of 30 and 90 days, which from after the discharge, which will assess mainly if there were any following ER visits related to acute pancreatitis, and if there were any hospitalizations related to pancreatitis after their discharge. And then do two basic things. If the patient developed new diabetes, new onset diabetes after their discharge, and if the patient is on any medication about that, and if the patient developed pancreatic insufficiency and pancreatic enzymes are required. Thank you. Mainly that will be the questions we'll be interested in. And,
Great, Strato, thank you very much. Moving along, where are we going from now? So in this brief amount of time, we try to explain to you what is our goal for this pilot initial attempt, how to do it, what will be the first steps in respect to contact your ethics committee, identifying the patients, start enrolling, briefly how to use REDCap, and what exactly will be the variables that need to be recorded. And within the next 2 weeks, that will be step number 2, we would expect to hear from you, all of you, even many other participants have shown interest, but they were not able to make it today. So actually, this webinar will be recorded, correct, Venkat?
Yes.
And will be available on the website for any of you that are were not able to make it today to view it at a different time point. And within the next 2 weeks, we will expect to hear back from you, each of you. We would expect to have a confirmation that you are interested and committed in participating. This would be extremely important because I realize that this is a timely commitment that will require a lot of time and effort from your side. And we need to know which are the centers that are really interested. Secondly, we'll give you 2 weeks to provide feedback on the ongoing protocol and data sheet. And both of them are available on the CAPER website. So if you really believe that there are some additions that need to be, as far as variables that need to be included, we can always do that. Again, I want you to understand that this is not the initial draft. There has already been a lot of work on that. So there is some small space for change and improvement. But again, we have to do it in a timely fashion within the next 2 weeks. Following that, each center which is interested should assign a PI who should be a gastroenterologist, preferably pancreatologist, already completed his or her training, and a research coordinator. And by research coordinator, we mainly are interested in the person who will be doing the vast majority of the data enrollment. And this person can be a paid research coordinator in centers that they already have studies ongoing and funding, but it could also be a trainee, a GI fellow or a medicine resident, someone who has shown interest, but this person needs to be committed in recording the data, and this will be the person that will be communicating on a frequent basis. As Vic mentioned, we plan to do it on a monthly basis, so as to be able to follow up and see how we do with enrollment, if there are any issues, if there are any mistakes or missing points that we need to correct. Finally, with this email, I would like you to share with us if there was any progress with the Ethics Committee and the ARB submission. Where do you stand with that? And as well as if a data transfer agreement is needed in your institution or not. And finally, you can give us you can work on that and give us a plan as far as how you have proceeded with identifying patients and follow up on them. So again, this is step number 2. That's going to be done via email, and the time frame for that will be the next 2 weeks. And then step number 3, which will be done in a month from now, will be a follow-up webinar where all the centers that have shown commitment and interest will be participating, ideally with both their PI as well as the research coordinator, where we hopefully will have some patients already enrolled in patients that have already ARB approval running, and we can go through technical details of recording issues and problems. And we hope that this will be a monthly commitment, the webinar. The potential date for the next webinar, it's Saturday, April 4th, at the same time, which is 8 a.m. Eastern time. Before I conclude and we go to discussion, as very nicely Dheeraj pointed to me, is I would like to give you an overall time frame. Again, this is a pilot study, but for us to be successful, we have to work on a very specific time frame. So our goal after we start enrollment, probably within the next 2 weeks to 1 month, is to have this study run for a year. And we aim to have, at the end of the year, a database that will include hundreds of patients with a lot of different variables recorded, as Stratos said, in many different aspects of the disease, including demographics, etiology and characteristics of acute pancreatitis, management, outcomes, and follow-up. And that will give us a tremendous advantage and ability. That's going to be unique. And at this point, we will have a great, a precious data set where we can analyze all these variables and also compare, correct, Dheeraj? Compare trends between different continents, different institutions, which will be extremely important. And I want you to understand, even though at this point the initiative is coming from the University of Pittsburgh, as David said very importantly earlier, this is an alliance, this is a collaboration. At this point, certain investigators from different centers that will show interest in certain aspects of our database can initiate different projects. Again, centers that have contributed the most will be the ones that will have a first shot in having the data, analyzing the data, and produce interesting results. And at this point, if Dheeraj, if you want to expand a bit on that, that would be great.
Thank you, George. First of all, I wanted to congratulate you for this tremendous effort upfront that has been put in, and I also welcome all participants. You know, as Dr. Whitcomb initially alluded, the North American Pancreatitis Study has really given us a great platform for collaborating with investigators around the country. And I think this is this initiative for acute pancreatitis will be an international effort. Over the next year, you know, once a certain number of patients are enrolled, this will give a lot of preliminary data for future work, which I think, you know, investigators around the globe will be able to use to see as to how patients have similarities or differences between individual countries or centers. It may give an idea with regard to what sorts of treatments are being offered and how they differ, and also provide information with regard to sample sizes if they want to do any intervention studies. Depending upon the interest, you know, it will be helpful to you know, come up with many different type of analyses that the participants of the collaboration can then, you know, write up or you know, advance. So it's just a tremendous opportunity for everybody.
Great, thank you, Dheeraj. At this point, we will try to do our best to give you the opportunity to share with us your thoughts and your comments. If you would like to talk, we're going to do it on a one-by-one basis. So any of you you can share with us your thoughts. At the beginning of of your talk, please let us know who you are and where you're calling from.
Enrique.
Yes. Enrique.
Hello everybody. Congrats for that great initiative. I think that this kind of studies are the future and are necessary, as you have pointed out. I had an experience in Spain with a similar project, just a national project with an acute pancreatitis database. We have shared this database with several centers in Spain, and we have joined 1,600 patients in less than 1 year. And what I want to ask and to discuss is, the purpose of this collaborative study is open to everybody, to any center that may want to join this, or this is oriented to a very defined pancreatologist specialized center. My experience is that if you open this to everybody, some centers that have not performed research but are willing to participate, you can join a lot of patients and a lot of data that maybe if it is very restricted to some specialized centers, you may lose these patients. Is it open to everybody?
Actually, I think that's a very, very good point, Enrique. And this is Enrique Di Maria from Alicante, Spain. This is a very good point. And and I completely agree that there are a lot of centers out there that they have not performed the research, but they have the patient volume. And there are investigators there that they are eager to participate, and they are more than welcome. And with your example from Spain and how successful you have done things within the last 1 year, that set for us an excellent example. Now, at this point, I would like to invite the Spanish Pancreas group to join us as well. We want to do that in a prospective fashion. So if you guys think, either all of you or some centers, that could from now on also chip in and provide data into this multi-continent approach, that would be great. And it might be also between you and me, Enrique, it might be interesting if we can share our databases, and if there are some points that we should add in our database that we're building that they are already in the Spanish group. So in the future, we might be able to, in a way, compare those databases. And I also thank you for the opening that you suggested for the South American groups, which are also welcome. So what we can do is within the next 2 weeks, whoever is really interested, even if they didn't have the opportunity to participate today, they can review our webinar online, and they can provide us email with their commitment, and we can move forward. Enrique, I don't know if you want to add anything on that.
No, I agree with you on everything. It's a great initiative and must go ahead.
Anyone else?
No, if anyone has any questions, please press the hand button on your screen so that we would know.
I know that earlier Mario Pelais from Mexico City asked if there are patients can include those patients. Mario, if you're still on, I meant to tell you that of course we can include those, but for example, the IV fluids or the early markers, we will need the outside hospital records. And from our experience with transfer patients, especially on recording of the 24-hour IV fluids, it's almost impossible. But other areas would be helpful. So I think from the beginning, we should include transfer patients. There might be some limitations in certain variables such as IV fluids, and we can address that when the time comes and we have all our data set completed.
Okay, thank you very much. I'm Mario from Mexico City. I appreciate the invitation, and I'm very interested in participating with all of you guys, and let's see what happens. I'm excited.
Great, Mario. Thank you. Anyone else?
I don't know.
We have no more hands at this point. So that means that either you were able to understand most of the things that we said, or you didn't do a good job, either one or the other. But at this point, I think Peter Lee. Okay. Peter from Cleveland, Ohio, you are on. Peter Lee, can you hear us? Unfortunately, Peter, we cannot hear you at this point.
Hello?
Maybe.
Can you hear me now?
We can hear you now. Yes, please, Peter.
Hi, yeah, this is Peter. I'm one of the GI fellows at Cleveland Clinic. I just had a suggestion to make regarding the data collection. I was wondering whether it might be a good idea to come out with a standardized definition of each of the variables, because sometimes, you know, just to give you an example, like etiology, you know, how do you determine whether someone comes in with a biliary acute pancreatitis or alcoholic pancreatitis? Some of the definitions might be perceived differently at each center. So I thought for data quality purposes, it might be good to come out with a standardized definition of all the variables. To give you another example, like recurrent pancreatitis, you know, do we include patients who were just discharged 2 weeks ago, never really had resolution of symptoms, who comes in with clinical pictures that meet the criteria? Is it recurrent, or is that continuation of a prior pancreatitis? So a definition of a time frame and things like that would be helpful.
Peter, thank you so much. That's an excellent point. We do have most of the details on REDCap while you enter in the data, but in addition to that, based on your comment, we're going to move forward and maybe create a spreadsheet or a handbook with certain on definitions of all the variables that we require, and we'll share that with you within the next couple of weeks to make sure that we are all understand the variables the same way, and that the approach will be uniform. Thank you very much for your comment. Becca, do you have anyone else?
No one to this specific, or unless you won't want to ask it up.
Do we have
Dr. Gailroot, please? No.
It's a webinar.
So at this point, I think, unless if I can actually, I don't know, Andres, would you like to say hi and maybe comment on anything? Andres Gailroot from Chicago, if you're there, if you're still there.
Yeah, no, can you hear me?
Yes, yes.
I'm still here. I think this is a great initiative. I'm very excited to participate, and I think the points that are being brought up are very good. I'm actually going to try to contact some of our colleagues from South America that I know they have a strong interest in acute pancreatitis to see if they can join us. I think it's going to be a great initiative and a great opportunity. And thank you so much for having me as well. Congratulations for the project.
Thank you, Andres. That would be at this point, if Dr. Triadafilou is on, and he would like to say hi from Athens, Greece. Dr. Triadafilou, are you with us?
Hi. Hello.
Hello.
Well, I'm Kostas. How are you? Kalispera. George, thank you for inviting. So it's an honor, pleasure, privilege to work with you and with all of us in the Alliance. A great project. We're currently translating the protocol. Actually, one of my colleagues has already translated, and we're submitted to our IRB We expect the approval of the IRB soon, and I promise to keep talking to our colleagues to participate in the project. Great honor for us. Thank you for inviting.
You're very welcome. Thank you for your kind words. Finally, Dr. Kochner.
From India.
From India, Dr. Kochner, if you want to say hi and a brief comment.
Yeah. Yeah, certainly. Hi, everybody. It would be great to have a global participation in this. I had a question that do we include only those patients who reach us within first 24 hours, or we can take patients who have been managed outside other hospitals in the first 24 hours?
We can definitely include transfers as well.
Okay, that should be good.
Such as IV fluids the first 24 hours will be missing, but that will be okay.
Okay, yeah, that should be good.
Great. Thank you very much for participating. I think at this point, we are already an hour within the meeting. We'd like to thank everyone again. It's exciting times. Again, please share with your colleagues, scientists and doctors that are interested in that they have the volume. And the webinar will be up on CAPER website for your review. And we're going to move forward. As we said, step 2, we'll be waiting for your emails with your commitment and your progress, sharing with us who's going to be the guy and the research coordinator in your center. And then we tentatively plan for our next webinar on April 4th. Thank you very much.
George, can I add something?
Please.
We have just finalized the agenda for Pancreas Fest 2015. It's Pancreas Fest website is pancreasfest.org or pancreasfest.com. We've set aside time for the groups to meet together face-to-face and to iron out some of these issues on Thursday afternoon. So we invite you to apply to Pancreas Fest. Many of you will be getting invitations if you do not already have them. We also encourage you to join CAPER if you're especially in the United States. There are a number of features that are provided, including electronic copy of pancreatology, a discount.
At this point, I meant to say, now we can hear you back, David.
Okay. I wanted to invite everyone to Pancreas Fest. Their information is on the website, and to join CAPER. If you join CAPER, you get electronic copy of pancreatology, you get a discount to CAPER, as well as the European Pancreas Club and other IAP memberships. There's access to travel scholarships. There's the ability to use the CAPER website for webinars of your own like this, and Venkat will help you with that. And a chance to highlight what you're doing at an international meeting, since we have set aside 4 talks just for these individuals to CAPER to present.
No, we just so it's really interesting what happened to him on the day. It's a long article, though.
You know, Irish Times don't have a paper anymore.
Yeah, I think it's really tentative.
Is also with us. I don't know, Michelle, if you can hear us. If you just want to say hi and a brief comment.
Can you hear me?
Yes.
Yeah, hi. I'm excited to be part of this. I think that great things will come out of this, and I'm so glad that it's going to be multinational.
Great. Thank you very much, Michelle. And I think at this point, we're going to conclude. Have a great weekend, everyone, and looking forward to your emails and seeing you again next month. Bye-bye.
All right.
Thank you all.
Thank you.